So welcome everybody to today's community chats, and we're going to be talking about autism. And for that, we have Dr. Michelle Dunn here from Einstein School of Medicine in the Bronx, part of Montefiore Medical Center. And we're very happy to have her because we've been looking for a specialist on autism for the longest time to bring information about autism to our families in Brooklyn and in the Bronx and Westchester and everybody who's watching us. So today, without further ado, I'm going to introduce myself. For those of you who don't know me yet, my name is Sandra Arevalo, and I'm the Director of Community Health at Montefiore Nyack. And of course, our guest, Dr. Michelle Dunn. And if you want to share your screen, you can start doing that now. And just to let all of our attendees know, this space is really for you. So any questions that you have, please write it in the chat or use the Q&A. Just to start putting your questions and comments down, that as we move along, I'm going to start asking those questions to our expert, Dr. Dunn. So whenever you're ready, Dr. Dunn, and I don't know if you just want to start by telling us, before we started, we were talking about how she got into autism, because there are not a lot of professionals that are actually specialists in autism. And she was telling me a very interesting story. So maybe you'd like to share that with our audience too.
Sure. First, let me thank you very much for having me today. I'm really excited about being able to talk to people about this topic because I think that there's a lot of misinformation that's out there, and it would be great to clarify some things. Yeah, I started out in the field as a special education teacher, and I actually worked many years ago at Bellevue Psychiatric. I was a new teacher, and I was the floating teacher, and I taught ages 4 through 21 every subject, which was terrifying. And I ended up at the end of the year feeling like I didn't know enough. So I went back to grad school and I started studying neuropsychology and neurocognition, and ended up developing some interest in autism. I had started it when I was an undergrad. And then I got recruited to work at Einstein with a very famous neurologist, Isabel Rappin. And it was a big study through the NIH to study the development of autistic children and kids with communication disorders. And so, long story short, here I am.
Yeah, well, I'm sure that Isabel wouldn't have recruited you if she didn't see something special in you. So I am the one who's very happy to have you today.
Thank you. Thank you. So I have a lot of information to go through. So I'll start going through. Sandra, I know you're going to ask me questions as I go. So that's just fine at any time. Let me see. There we go. Okay, so when we first talked about me giving you this information, Sandra asked for specific things. And so I wanted to go over what I'm covering today. What is autism? What is the prevalence? How frequently do we see it? How is the diagnosis made? And at what age is it usually diagnosed? It's also important to go over signs and symptoms because parents are the first ones who are going to notice that something is different. And so it's really important to know what those signs and symptoms are. We're going to talk a little bit about causes and risk factors, but nearest and dearest to my heart is treatment, and the different types of treatment. I think it's really important to be able to consider who people with autism are, what their processing profiles are, how they think, and how that impacts how the different aspects of autism are treated. I'm going to talk a little bit about diagnoses that can be confused with autism, how autism impacts one's life, and then we'll talk about specific tips for parents that can be very helpful in raising kids with autism. So, okay, what is it? Autism is a complex neurodevelopmental condition. So it is lifelong. Now, that doesn't mean it doesn't improve. With the right intervention, with the right focus, autism can improve. It is a developmental disorder of brain function. It's not a disease because there are lots of different causes of autism. And there's no biologic test. It's not like we can do a genetic test or we can do a blood test or anything like that to find out whether someone's autistic. It's diagnosed on behavior. And this is really important. It's not diagnosed by cause. It's not diagnosed by what's going differently in the body. It's diagnosed by behavior. Okay, so the prevalence of autism, it's very interesting how this information's collected. So let me skip to this slide. So the prevalence is 1 in 36 children in the United States. This seems enormously high. And that's why we really need to pay attention and know about this disorder, because everyone's life is going to involve probably a person with autism in it at some point along the way. So how do we know what the prevalence of autism is? There is the Autism and Developmental Disabilities Monitoring Network. There are 11 sites across the United States. And what they do is they collect information on 8-year-old children. And they look for, in educational evaluations and developmental records, medical records, evidence of an autism spectrum disorder diagnosis. So there's either a statement of the diagnosis in an evaluation. They've been classified as autistic for the purposes of special education. So those children are identified, and then that's how we figure out what the actual prevalence is. Okay, so we said 1 in 36. Autism occurs in all racial and ethnic groups. There's a 4-to-1 proportion, or 4 or 5-to-1 proportion of boys to girls. And about a third have an intellectual disability. Now, this is interesting because there's such a range of numbers that are reported with regard to what percentage of kids have an intellectual disability. It's anywhere between 25% and 33%. So this information is from the CDC. The other thing that's really important to know is that each year about 45 to 50,000 ASD children become adults. And this is where we have the issue, helping people transition into adulthood and have effective adult lives. So we'll talk a little bit more about that later. When we talk about diagnosis, this is a very important distinction to make. So we have different levels of explanation and diagnosis. We can explain things at the level of behavior. We can explain things at the level of pathophysiology. Now, pathophysiology is basically what is going on in the body that is producing the symptoms. And we have etiology, which is the cause. Again, I want to stress that autism is diagnosed at the level of behavior. So it's specific behavioral syndrome. This is the diagnostic criteria for autism. There are 2 different areas in which people must meet the criteria. One is there need to be significant and persistent deficits in social skills, social communication, social interactions. The other area is that there need to be deficits in the area of having restricted and repetitive patterns of behavior or restricted and repetitive interests and activities. So here in younger children or kids with intellectual disabilities, we'll see a lot more motor stereotypies, maybe flapping, those kinds of behaviors. In other kids who are not intellectually disabled, we would see more of the verbal kinds of perseverative behaviors or repetitive behaviors, maybe fixated interests on things like trains or planes. But, I was talking to Sandra before we started, there's a broad range of things that kids can get fixated on. And what I find in a lot of the teenage girls on the spectrum is that they can get fixated on social relationships and talk perseveratively about these social relationships. Does this person like me? Should I say this in this text? And really obsessing about those kinds of things. So these are the 2 areas that make the diagnosis. And clearly, when we talk about treatment, we are treating the social aspects. So how do you behave socially? And we work heavily on social communication. And then we're also addressing the restricted and repetitive interests and the cognitive inflexibility really having trouble being flexible about how they think. Okay, so the diagnosis of autistic spectrum disorder is made actually around the age of 3.5, 4 years old, a lot of the time. It's made earlier in children who have intellectual disability. So usually about 10 months earlier, at about 43 months in those children, and on average at about 53 months in kids without intellectual disability. But I have to say, because this diagnosis was not made a lot when a lot of 30 and 40-year-olds, 50-year-olds, even 70-year-olds were young, what is happening now is we are finding that there are more and more adults presenting for diagnosis and saying, I think that I have this. And so they want us to see whether they do, because it has really significant impacts on their life. The other time that autism gets diagnosed is in a very special circumstance where there's an autistic regression. So a child may be developing pretty well, developing language, developing socialization, may be interactive and smiling. And then all of a sudden there's a point, usually somewhere between 12 and 30 months, the average being 21 months, that there's a regression. And this has been reported by about a third of parents. There is usually an improvement after a plateau, but something happens and there's this regression. When it happens, it's extremely important that your pediatrician be consulted, that a pediatric neurologist be consulted. And the triggers, we don't know exactly what they are, but maybe subclinical epilepsy, maybe some kind of immune condition or infection. We're not really exactly sure. But this is another time when autism can end up being diagnosed quite early because something big like this happens. Yeah, Sandra.
Vaccines, like that whole um, argument about vaccines being one of the triggers for autism. What do you have to say about that?
I was going to get to that. Okay, I think it's a disaster, actually, that people ever said that vaccines were a cause of autism. The initial study that was done that said that vaccines were causing autism has been completely discredited. You know, the investigator had to retract everything he said because the data were incorrect. They were tainted. And so this has had a profound and far-reaching effect. It is very concernful that children would not be vaccinated for measles, mumps, and rubella. There is really no reason, with regard to autism that should ever happen. And there have been large epidemiologic studies done that demonstrate that there is no association between the vaccine and autism. So I'm glad that you asked that question. I was definitely getting to it. Okay. So associated characteristics, these are not the things that make the diagnosis, but these are very important things to know about people with ASD. In terms of their intelligence, it's not a defining feature. So you can have people who have intellectual disabilities all the way through to very superior, genius range IQs. So that is not what makes the diagnosis. Remember that it's the socialization and the repetitive interests. The cognitive profile is usually uneven. So performance IQ, which is things like building with blocks, making designs with blocks, that kind of problem solving, visual spatial problem solving, is usually better than verbal communication. Although there is a subset where verbal communication is better. So you always have to look at the profile. And again, we talked about impaired cognitive flexibility, which can impact creativity. Here is the general neuropsychological profile. So the strengths are often in visual processing, visual perception, and visual spatial abilities. Simple language is usually a strength when kids have language, simple auditory memory, simple visual memory, and concrete information processing. So what I mean by that is if there's information that's available and it's there visually and it's not leaving, it's not going anywhere, then that's the kind of information that's processed most effectively. Auditory information is fleeting. So it's there and it's gone, and that's much harder to process. And we saw, I also did neurophysiologic research initially in my career, and we saw that there was slowing of auditory processing in kids with ASD. So verbal abilities tend to be weaker, auditory processing, and then processing things that are complex. So what I mean by complex language is a novel or a conversation, something that involves topics that are moving or sort of the hierarchic structure of language. So there's a main topic, and then there are subtopics, and then there are details that go with those. So that kind of complexity can be difficult because for many people on the spectrum, organization is difficult. It is very easy to see all the details and remember the details of something, but seeing the forest for the trees, really understanding the main idea versus the individual details, that's something that's difficult because it's hard to organize. Okay. In terms of attention and executive function, so impaired joint attention, you will see a child who is not really looking at the same thing as you or trying to get you to look at the same thing that they're interested in. A hyper focus, getting stuck on a particular thing, being distractible at the same time. So they may get stuck on one thing, but then there may be something else that will totally distract them and pull them off. Again, disorganization of belongings and planning their time and activities when they get older, and trouble moving their attention from one place to another. So attention's kind of sticky. So if they're focused on one thing and then something happens over here, like so many parents will tell me a bomb could go off in the room and my child on the spectrum will not even notice it. And that's that sticky attention, moving their attention from one thing to another. Problematic behaviors. It is very common for young children on the spectrum to have trouble with emotional modulation and to have big, big tantrums. This is one of the most difficult things for families, I think. It interferes the most. And very frequently, families with young children will come to me, and that's the first thing they're asking. How do I help them to regulate themselves? Later on, anxiety and excessive fears, sometimes destructiveness, sometimes aggressiveness during the tantrums. Sometimes we've seen injury and pica, which is, eating things that are not edible things. So all of these things can come up as problematic behaviors. The ones we encounter the most are anxiety and excessive fears and the impaired emotional modulation. And they kind of go together because they're having trouble regulating that. Okay, so signs and symptoms. What are things that maybe parents can notice or pediatricians are noticing early on? So in young children, one of the things is you'll see that if there's an infant that has a head lag beyond the time when it's expected to stop, which is about 3 to 4 months. So what is that? When you lie a baby on their back and you hold their hands and you pull them up into a sitting position, does their head hang back or do they bring it up and right their head? So babies that have head lag beyond the time when they're supposed to, about 75% of them are later diagnosed with autism. If you see no babbling or pointing to objects by the time they're 1 year of age, that's a red flag. No single words by 16 months or 2-word phrases by the age of 2. No response to name. And, it's calling their name. You would think it would get them to orient, but it's the same thing as the bomb going off in the room. Loss of language or social skills, not smiling or being socially responsive, not making eye contact, like we said, poor joint attention, and then this thing of excessive lining up of objects, or the motor stereotypies of flapping and things like that. Okay, so I have a little video here. I'm just going to show you a small part of it. Let's see. Oops, sorry. Let me see if I can play it. There we go.
All right, Charlie, look there.
So you see this little girl lining up all of her dishes. And she clearly needs this to happen in a specific way. And then she fixes it the way that she wants it. Mom takes away one dish to see. Okay, poor little thing. Okay, so you can see, I mean, this is, I wanted to just show this to make it more real, that this is what this can look like. And she's getting so frustrated and so upset by this. Now, this is a rigid, inflexible behavior. When we talk about treatment, this is something where we would intervene and try to get her to be more flexible, because that inflexibility is going to negatively impact other things that happen in her life. So the signs and symptoms in young children actually are really very much focused on those kinds of repetitive behaviors and language development. If you noticed, we're looking at aspects of language development. Here in the older kids, we're seeing that it's really more focused socially and on other kinds of repetitive behaviors. So having trouble making friends with peers, having trouble sustaining conversation with others, especially on topics of interest to others. It's very common. A big red flag is when a kid can only talk about their own topic. And even when someone is talking about something else and trying to engage them in that topic, they won't go there. Absence or impairment of play, imaginative play, repetitive use of language, restricted interests. So the things that make the diagnosis. But these stand out as red flags in older kids. Now, why do I say this about older kids? Because these are the kids that usually develop language, and so they're diagnosed later. So if you see normal language development, people tend not to think that there's that much going on. It's not until they get older that they're struggling with the friendships, that they're struggling with talking to other people, playing with other people, that it becomes an issue. Okay. Etiologies. So what are the causes of autism? Well, there are rare causes that could be, intrauterine rubella, early, brain damage, prenatal exposure to different kinds of toxins, those kinds of things. But those are rare causes. The most prevalent causes are genetic. And they can be completely novel new genetic mutations, or, we'll talk about how things seem to fit together in families as well. There are also single gene defects that produce the autism behavioral profile. So the single gene defects, I won't really go through these in any depth, but here's a list of them, some of them. This is where I was going to say the part about the vaccines. But also people think that maybe gastrointestinal yeast infection or allergies to gluten and casein, those kinds of things could produce autism spectrum disorder. And I would say that these are not even remotely proven. I would say that if a kid gets sick or has an allergy to gluten, that it can exacerbate, any kind of behavioral issues. But I would say that these are not causes.
Dr. Dunn, is lead poisoning considered a rare non-genetic cause?
That's a good question. I am actually not sure about that. I think that certainly lead poisoning could produce the behavioral syndrome. But yeah, I'm not exactly sure. Okay, so in terms of the genetics, though, like we said before, 4 or 5 boys to 1 girl, 18 to 20% of siblings have ASD.
Mhm.
Additional siblings may have language delays. 40% of first-degree relatives have a broader autism phenotype, which includes social, communication. Sometimes we see manic depressive illness in families. And affective and anxiety disorders are very common in first-degree relatives. We will see OCD, we may see ADHD in first-degree relatives as well. So, some people would consider these things the broader phenotype. If we look at twin studies, I think this is very interesting. When you look at dizygotic twins, from two separate eggs, we see what, a 31 to 36% concordance between the two twins for autism. But when we look in monozygotic, I mean, we're talking 77% in males and 50% in females. So quite different, quite much higher in monozygotic. Okay, risk factors. Risk factors are having an older sibling with ASD, having complications at birth. So anoxia also can sometimes produce the autism syndrome. Born to older parents, or having those specific genetic or chromosomal conditions like I showed you before, Fragile X, etc. Okay, treatment. So this is really important. There is always a treatment team for people on the spectrum. When a child is first identified, hopefully it is by the parent saying something's up, goes to the pediatrician, and the pediatrician is able to refer the family to other specialists who are on this list. Usually a child with ASD is seen by a neurologist, a psychologist or a neuropsychologist to evaluate their processing profile, their intellect, an audiologist to make sure that they're hearing, speech language pathologist, occupational therapist, maybe physical therapist, psychiatrist. So this is usually what the multidisciplinary team looks like. Early intervention is the key. The earlier ASD can be identified, the earlier there can be intervention, and the better the child does. And when we talk about early education or early intervention, it's not just for the child, it's also for the parents. Because raising a child with ASD is very different than raising your average child. You need to know how to respond to the tantrums. You need to know how to respond to the rigidity. You want your child to improve. And so you need to be educated in the things that you can do to help them improve socially, to help them to be more flexible in the way that they think about things, to help them to actually engage with their peers. Focus on social skills is critical. It's one of the defining characteristics, so that has to be there. Intelligence influences prognosis and also influences the type of intervention. So we'll talk about different interventions in a minute, but applied behavioral analysis, which is basically reinforcing the child for appropriate behaviors, and having a planned way of doing that is appropriate for kids that maybe have a lower intellectual level. Whereas CBT, which is cognitive behavioral therapy, is much more of a talk kind of therapy that involves changing a person's thinking to help them feel differently and behave in a different way. And that's really much more appropriate for older people with ASD and for people of higher intellectual levels. I'm going to say this a number of times. No one treatment fits everybody. This is so important. There are those core characteristics, but even in those core characteristics, there are different levels of functioning. So, you may have certain abilities socially and lack other abilities socially. It's important to define exactly which abilities are intact, which are strengths, and which abilities are areas of difficulty or which are challenges and obstacles. So everyone has a different profile within the diagnosis of having social skills and having repetitive interests and cognitive inflexibility. It's important to know that there's no cure, but there are coping strategies, and we have people who have grown up and gone out into the workforce and are living independently. So there is a wide range of functioning, and there's a wide range of potential. And it's very important to provide people with ASD the insights and interventions in order to be able to allow them to function, to their potential. It's so important to give everybody that opportunity, actually. Psychotropic medications can be useful, but I also want to caution people that they're not the panacea. They're not where you go and you get a pill and it fixes it. That's not what happens. And unfortunately, medications, they don't target the specific symptoms of ASD. What they do is they target things that sort of surround ASD or go with it. So emotional modulation issues can be helped by medication. Depression or anxiety can be helped by medication. But it's not, socialization is not fixed by medication. Okay. So these are the areas that require intervention: socialization and communication, including prosody, which that's the melody of speech and the rhythm of speech. So sometimes when you hear a person with ASD speak, the melody and rhythm are unusual, and so they sound unusual. Helping to remediate that puts them in a position where they do much better, because unfortunately, that's the thing that most people look at first, how they communicate, and accept or decide that they're not going to get the job based on that. Of course, the other things: perseveration, preoccupation, and rigidity, auditory and sensory issues, emotional modulation, planning and organization, and motor function. So we're always looking to see whether people need intervention in these areas. And again, we're individually tailoring the intervention. So people say this phrase all the time now: when you have met one person with autism, you have met one person with autism. So the interventions need to address that one person's symptoms and needs. So there are so many different kinds of interventions that have been focused on treating ASD. There are behavioral interventions. A minute ago, I mentioned applied behavioral analysis, or ABA. So that's that type of intervention. There are developmental approaches. So those developmental approaches would include things like speech language intervention, occupational therapy, physical therapy, sensory motor integration. There are educational interventions where the classroom is completely geared all day long to treating the person with ASD. In that classroom, there are lots of things that are done that consider the typical profile of someone with ASD. So, for example, if we know that people are stronger at processing visual information than auditory information, then we have the visual schedules up. We have a lot of visual information and input, a lot of gesture, really pointing out facial expression, really using the visual in order to support the auditory. We do a lot of work in the schools. We have a program called SOS, Social Skills in Our Schools, which focuses in on educating not only the kids with ASD, but their peers. And we also have peer mentoring as part of that program. So that's something that's delivered directly in the schools. Social relational approaches would be things like social skills groups, and something I'll talk about in a minute is called floor time. They're really focused on getting or helping and supporting a person with ASD or a child with ASD to interact and socially in an appropriate way, but also enjoy the interaction instead of finding it something that's really scary. pharmacologic interventions, psychological interventions, which the psychological interventions would include things like psychotherapy, cognitive behavioral therapy. And then the other thing I'm just going to comment on is just remembering that the idea is to always use a child's strengths to help them get beyond their obstacles. So if there's a strength in processing concrete information, visual information, then we want any of these approaches that are listed here to involve concrete hands-on activities, visual activities. So, for example, some CBT is done where you're sitting in a room and just talking.
Mhm.
Instead, it's essential that there be all kinds of visuals available in order to support processing. The same thing, we were talking before about when a kid comes into a doctor's office, it's incredibly helpful to have visuals to help them process what's going to happen, what is happening. Okay, so the other
Dr.
thing.
Dunn, sorry to
Yeah.
interrupt. Regarding the pharmacology, at what age can children start taking medications?
I think that that's usually determined by the psychiatrist, but my bias is to try behavioral interventions before you go to the pharmacologic interventions. And then if you find that you need the support of the pharmacologic intervention so that they can focus on the behavioral work that you're doing, then we move in that direction. I have had kids as young as, 6, taking medications. But usually I leave that to the psychiatrist. And again, like I said, we go for the behavioral interventions first. Okay. So just some other concepts, and this is really important for parents, teachers, everybody. The idea is not just to like extinguish or put out the inappropriate behaviors and say, no, 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 you can't do that. It's really important to teach kids what they can do instead. So if you're telling them, stop pulling on that kid's shirt to get their attention or stop pushing to get their attention, just telling them to stop is not enough, because if they're used to doing that over and over again, that's an automatic behavior. You can't stop an automatic behavior unless there's something else to interfere with it. Plus, they need to know what else to say. And what they're trying to do is they're trying to ask, will you play with me? So they just need the words to substitute. It's also important to consider that it's not enough to just teach a skill. You have to teach how to implement it, but also when to implement it and what the skill means and why you want to do it. So you want to teach also about the consequences of using a skill, and you want to give them experience so that they understand that there's a positive consequence to using these skills. We want to think about not just acquiring the information that they need to know, but also because of inflexibility of thinking, it's hard to generalize from one situation to another. So if you teach in one, like if I teach something in the therapy room, the kids will not necessarily do it at home. They won't necessarily do it in the classroom. So we have to help them to generalize it to other situations as well. And then after that, we want to really reinforce and rehearse and, and promote using these behaviors, over and over again. So it's not just enough to teach the skill. It has to be generalized and maintained and become really fluent and part of who they are. I'm going to skip this one because it's too much. So I just wanted to give you an example of, some of how we do this. The idea is to teach some social rules and do it in actually a relatively inflexible way at first, and then introduce the flexibility after. So we teach parts of conversation, how to initiate conversation, reciprocity, listening. As the kids get older, we teach the correspondence between the type of conversation you have for the level of friendship. So, for example, you're not going to talk to the guy in the bagel store in the same way that you would tell your parent about your day, and nonverbal communication. So parts of conversation, an example would be 4 parts: greeting, small talk, main topic, and closing. And you spend different amounts of time on each of these depending on who you're talking to. Rules for answering a question about yourself. And this is typical kids too, right? You ask your kid at the end of the day, how was your day in school? And they say good, and they leave. So what we try to promote is you say good, and then you say something that was specifically good, and then give a couple of details about it. This is just the graphic that we use, the visual that we use when we start teaching about levels of relationship and how they correspond to different kinds of conversation. So for example, with acquaintances, you're having small talk just to be social. When you want to get to know someone better, you're using something that we call SWIFT, which is you talk about these topics of school, work, interests, family, friends. You ask questions about it, and you talk about them. As you get closer, you tell stories, you talk about news. When you get even closer, you start talking more about feelings, thoughts, and opinions. And then when you're in your inner circle, you're talking about private matters as well. So this sort of shows them how you not only understand what kind of conversation you have with someone at a different level of friendship, but it also shows, like that arrow that goes around in a circle in the middle, shows how you can actually use conversation to develop a friendship. Okay, and this is just that schoolwork, interests, family, friends, and this is a graphic we use to teach them that you can think of questions about school past, come up with a question to ask, school future, come up with a question to ask. We use graphic organizers, web organizers to help organize talking about a topic. So it's not just one sentence or talking about a couple of details, but this gives them the visual in order to be able to organize talking about something a lot. And then, of course, telling a story. Okay, so any questions? Sorry, Sandra, I'm talking a lot.
No, so far we're good. Keep going.
Okay. So what diagnoses? This is a long list of diagnoses that can be confused with ASD. So people who have what would be considered subthreshold traits. So things that sort of look like it, but don't quite meet the diagnosis. People with ADHD, with attention deficit disorder, people with obsessive compulsive disorder or social anxiety. These can be confused, but how do you differentiate them? Well, people with obsessive compulsive disorder would be obsessing about things, but probably have a reasonable ability to converse socially or interact socially. With social anxiety disorder, it's fear of interacting, but not necessarily having an issue about knowing how to interact or wanting to interact. Communication disorders, particularly semantic pragmatic communication disorder, which affects the social communication, but it may not affect other aspects of socialization. So basically, when we look at these diagnoses that could be confused with ASD, these are diagnoses where one aspect of it or an aspect of the diagnosis looks like it could be an aspect of ASD, but they don't meet the full criteria. Reactive attachment disorder is where a child has been neglected, as they were growing up, and so may be somewhat isolated, socially isolated. And so this could be confused with ASD. In adults, antisocial personality disorder, schizophrenia, depression, have characteristics in common with ASD, but do not meet the full criteria. Okay, now this is my busiest slide. Sandra had asked, how does autism affect life? It affects life in many, many ways. As a child is growing up, it can be very stressful for the individual and the family. Emotional regulation issues and tantruming are, a significant obstacle. certainly affects communication and social interaction, in terms of having few or no friends. And just because you have ASD doesn't mean that you're necessarily unmotivated to have friends. Pretty much all of the people I know with ASD want friends. And so it's just really difficult to make them, uh, unless you develop the social skills to do it. So that's a significant impact. A lot of anxiety about, figuring out how they're going to do things, or understanding sometimes in the young adults I work with that maybe they are not completely processing something that was said. And so there's anxiety about that. Getting stuck and not being able to move on to the next thing that they need to do. Or in college students that I have, getting stuck on a favorite activity, something that they really enjoy doing, maybe video games or programming or something like that, but not being able to disengage in order to be able to get their college coursework done. Difficulty with transitions, and problem solving, perspective taking, paying attention, planning and organizing. So there's this big list here, and this could be very, very scary for people. But what I want to say is that for each of these things on this list, there are ways to intervene and to support people so that they are able to do better. The quality of life that someone with ASD has depends on monopolizing on strengths and acknowledging where the obstacles are in the processing profile. So I say to the people that I work with a lot that it's easy to just focus on your strengths, but if you're able to acknowledge your obstacles and work on those too, using your strengths, then you can really do well. And I think that that's what parents need to know when working with their young kids. And I think that that's what young people, or adults on the spectrum need to know, in terms of helping, to really develop and have the kind of life that they want to have. And the thing is, there are so many strengths here too, a lot of the time, where others in the community could benefit from those strengths. Okay. So now, Sandra asked me for tips for parents. So I think this is really important. So because kids on the spectrum can be quite inflexible, it's important to structure the day and give them predictability and consistency. If a kid knows, if they're able to predict what's coming, then their attention is going to be more focused on what's going on. And it's going to be easier for them to move from one activity to the next. So if you have a schedule, a visual schedule, and they know what's coming and they can move through their day using that visual strength, it is much easier for them to shift their attention from one place to the next. And so it's less likely that you'll have as many difficulties with transitions. And this really helps kids to learn to make transitions more easily. Setting clear limits and boundaries, and praising the positive rather than focusing on the negative, because it's so easy when you have a child who's tantruming, especially in public, to need them to stop and to tell them to stop and really be focusing on the negative, rather than maybe taking them someplace else, getting them to calm down, and then saying, "Great job calming down." There's a big difference in the way that kids react to that kind of thing. Supporting a sense of responsibility for themselves. This is important as kids are growing up. And again, this is not just for kids on the spectrum. Emphasize thinking about consequences of their actions so that they can ultimately make choices. Encourage flexibility. So, some parents say to me, "It's so hard to take my kid to the grocery store. It's so hard to take them out of the house." It is very important to give kids with ASD as many experiences as you can, because the more experiences they have, even though it's difficult for you when you first do it, the more flexible they become. Talk about solving problems, and as they get older, develop insight into themselves so that they understand their strengths and weaknesses. They understand who they are. Teach these things, but also it's really important to have fun engaging in what they like too. It's really important to have the joy of interacting with someone else. So sometimes you have to jump in on what their favorite topic is and do it with them and have fun with them so that they can develop that feeling of joy in social interaction. Of course, you're going to set limits on those things as well, so that there's a time and place to engage in something that they tend to perseverate on. Like if they're really into trains, okay, so there's a period of time where we can talk about trains and have fun with trains and interact surrounding that. But then other times of day, it's not okay to do that. I remember I had one kid who really liked looking at the ceiling fan in his room, and he was perseverating on fans, and he had 15 minutes of fan time every day, and that was it. And it worked out very, very well, because he really did learn to be more flexible. And the biggest thing I would say to parents is have self-compassion for yourself. Take care of yourself. Get rest, get sleep, get exercise. Every second doesn't have to be focused on your autistic child. It is possible to bring some kind of respite into the home. And the other thing is, if your child tantrums in public, I guess my best advice is to say, that's not you. That's not about you. It's about them and their struggle. And so it's not a reflection on who you are as a parent. So many parents come to me and say that they're so embarrassed and they just don't know what to do in those circumstances. And again, I think that this is the self-compassion that parents need to have, that you are working very hard with your kids. So the other thing I would say, let me skip over this for a second, is collaborate with your professional partners. Really communicate well. Get intervention going as early as possible. You are a partner, so let them know what you're seeing at home. Talk about the circumstances that you're dealing with and ask about how to deal with them. So that communication is key. Ask for parent counseling as part of your child's individualized education plan, and know the activities that are being done by the professionals so that you can support them and reinforce them in your home environment. And that's a mouthful. And that's everything that I have for today. Sandra, do you have questions?
Well, we're running out of time, but I do. How many kids go undiagnosed or underdiagnosed, you think?
I think it's really tough to say. I think we're doing a better job of it, because when we look at the prevalence now, I think that we're just identifying kids a lot more effectively. Um, yeah, at this point, it's hard for me to say, because in my experience, of course, I'm seeing all these kids. So, I'm not seeing a lot of the kids who are not diagnosed. But when I walk into a school, I would say that there are always a couple of kids, where I would say, that kid might be on the spectrum. And they haven't been identified. So I'm not sure, but I do think we're doing a better job than we had been.
I loved all the tips that you gave for parents. I think and especially the how did you call it?
Self-compassion,
The
yeah.
self-compassion. I think that's very important. And also, not caring about what other people might say, because I know that sometimes, you feel embarrassed because your kid is throwing a tantrum in the middle of the supermarket aisle, and you're like, oh my God, I can tell, in some parents' eyes that they just don't know how to react themselves. So that's really good. Now, I'm also thinking about those kids that might be on the spectrum, but not so clearly. Any advice to parents who might be thinking, is something wrong with my child? But it's not so obvious, that you're going to go and get your child diagnosed.
Yeah. I think if you can, it is worth asking the questions. It is definitely worth um trying to have some kind of an evaluation, because even if your child is not on the spectrum, but you feel like something's going on, that's an obstacle for them, it's always worth trying to figure out what that obstacle is. And then, and also knowing their strengths, being able to help them use their strengths to get around that obstacle. It may not be ASD, it may not turn out to be ASD, but it could be something that's still interfering with their ability to function. So it's worth knowing. I mean, knowledge is power, right?
Yeah, absolutely. And last question, because I know that we run out of time, but I knew that was going to happen today. So, kids who get diagnosed, or even adults who get diagnosed, are they eligible for different resources, maybe from the government, insurance, health insurance wise, something like that? Because I know that, for example, with other mental health or behavior disorders, like people get scared of being diagnosed because there is some stigma around it. What
Mhm.
about with autism? I guess I made those two questions instead of one.
Right.
Resources and a
And
stigma.
stigma. Yeah. So yes, I do think that there are a lot of people who are afraid of the stigma. And I think as bright uh, people with ASD are growing up, they talk a lot about masking and trying very hard not to let anybody see. But there's so much energy invested in masking. It's so hard, to do that every single day. And it's also unfair, because they are people in the world, doing the best that they can. I mean, working really hard, and these wonderful people. Why should they have to mask that all the time? So the stigma issue is, I mean, I could do a whole hour on that. As far as resources, clearly there are your committees on special education. There's the preschool committee on special education in your own school district, and the committee on special education in your own school district. And so there are lots of services that are available and evaluations that are available free of charge through your district. If you come to your committee on special education or your director of special ed and say, something's up with my kid, I really need to find out what's going on. And then you can see what services you can get through the school. Parents will also go to outside evaluators like me sometimes because they feel like they're not getting everything that they need. But those are things that are available free of charge. It's a free and appropriate education. What happens is that kids on the spectrum can potentially go to school until they're 21 and be covered by the CSE until they're 21. When they're 21 and they graduate, then they fall under adult services. Adult services are not an entitlement. They all have to be applied for. So there's like OPWDD you can apply to in order to get supports. You can get financial supports and things like that if you qualify for those services. And there are specific criteria for that. The unfortunate thing is that there are a subset of very bright people with ASD who do not qualify for any of those things, any of those services. They may be able to get some help from Access VR in terms of support with being able to get a job or some job coaching or things like that. But some people are sort of just left without really being able to access much at all unless they can access it privately, unfortunately. And that's really tough. And so, we've been working on our Capable program here. And that's a program that's specifically being built and designed to help young people transition into adulthood.
And that is state by state, correct?
It is, yeah. The labels that I'm using are state by state, right? So OPWDD will not be the same label as in another state. But there are adult services, but there are specific criteria for accessing those services. It's not exactly the same. You have much more access. And the other thing is, although parents have to start the process when kids are in school, Schools will follow through, keep evaluating, watching how the kids develop all the way through. Once you get into adult services, that's not necessarily the case. It's the onus is much more on the family and on the person themselves. And even in college, I mean, it's the same thing. If these guys go to college, there's no one who's going to come after them and say, let me help you do your homework. It doesn't happen that way. You have to access the services yourself.
Mhm. So to all of our participants today and all of those who are going to be watching the recording, I think you're going to agree with me when I say that we have found a treasure here. And I will say a hidden treasure, but I don't think it's going to be hiding anymore. So Dr. Dunn, how can we connect you with our community in case somebody needs services?
Okay, well, this is we are at Montefiore with the Montefiore Einstein Center for Autism and Communication Disorders. We're in Yonkers, and yeah, I mean that's that's us. That's where we are.
Very, very good. So now you heard it, and they're not too far from Brooklyn, so just a few minutes away. And again, it's a hidden treasure that is not going to be hiding anymore. I'm sure that a lot of people are going to be watching this and requiring your services. So thank you so much, Dr. Dunn. I'm sure we're going to be keeping in touch for not just for community education, but other needs that we have. And I really appreciate it. And look at that list. Come on. Oh my God.
So I figured I would put this up, you know, if you can make this available to them.
Yeah.
These are different intervention methods that may be very useful. And one of the things I want to say is, you know, our service, what we've found is that many people access the service and we don't have the manpower always to meet all of the needs. So one of the things that we've developed is that SOS program to actually implement in schools. And so that's where social skills actually starts being taught in schools. And so I think that that's the way to reach more and more people.
So let's start there. Let's start at the school and see what happens.
That's right.
and start, you know, filtering down. And
that's exactly right.
You know, all of our kids who are out there with some autism are going to get the services that they need. And parents, please don't ignore those signs and get the help that you need for your kids, because I know that the earlier they get intervention, the more functional and successful they're going to be in life. They deserve it and they have the chance. So thank you so much again, Dr. Dunn.
Thank you.
I will see you next week. Next week, we're going to be talking about domestic violence. It's not such a happy topic, but we're going to be talking about how there is an organization here in Brooklyn that is helping a lot of people change their lives after living with domestic violence. So I'll see you next week. Thank you so much to all.
Thank you.
Take care.
Bye.